All right, I think I'm going to get us started again just so we stay on schedule. Sorry to politely end your conversations. There was one more question in the chat about, is there a correlation between Hirschsprung disease and infertility? So
I am not aware of a correlation between Hirschsprung's and infertility. Sometimes surgical issues can cause infertility. You know, if somebody's had surgery in their pelvis for a pull through, or because of complications from a pull through, then that could interfere with you know, the ovaries and the tubes. But just in general, I'm not aware of that correlation. No.
yeah, I think one of the terms that we use in medicine specifically here is fecundity, which is the ability to get pregnant kind of within a year of trying naturally the first time. So pelvic surgery has been associated with a decrease in so-called fecundity, or the ability to try, but fertility itself, the ability to get pregnant in general as related to Hirschsprung's disease, I don't know of any type, but certainly pelvic surgery for females is a risk factor for decreased fecundity. All right, we'll close out the last session and we'll let Dr. Joerger start with the late morning session.
Thanks. I appreciate the opportunity to talk to you guys today. So I'm going to talk about multidisciplinary care for Hirschsprung's patients, which I think is sort of being highlighted in the various talks that we're getting today. So as many of you know, you have frequent follow-up in the first year after surgery, but often need to keep in contact with your team going forward at some interval, depending on how things are going, to aid in sort of timely identification of any problems that might be arising. As Dr. Langer said, overall outcome is good for patients over time, but there certainly can be things that come up that will need to be addressed by a care team. And so, as we've talked about, some will have continued issues with constipation or incontinence. There might be food intolerance issues, or just different symptoms of bloating and things that you might need help with identifying causes to and solutions to. Certainly different psychosocial implications can come up, and often will come up over time. So it might not be something that's present in infancy or in toddlerhood, but might become more of an issue for patients as they age and become teenagers and things. So certainly scars or surgical scars might become more bothersome to patients at some point. Kind of the emotional effects of impaired bowel function may not be as prevalent of a problem early on, but may become more of an issue over time. So kind of long-term care with a multidisciplinary team and transition to adult care as needed is important. And I'll talk a little bit more too about kind of the idea of having a more structured transition to an adult provider as well. So as we know, HD is a complex medical problem, and there can be varied social and health outcomes that can come up over time with age and the different developmental status of the patient. So there's been efforts to kind of assess what the long-term bowel function is in patients with Hirschsprung's and how that relates to kind of quality of life. And I think we're talking about that earlier, that maybe, you know, sometimes there can still be alterations and impairment in bowel function, but does that really affect a patient's quality of life? And that might differ at different stages of life. So studies have looked at, you know, health-related quality of life in patients with Hirschsprung's, and some of these studies are a little bit equivocal. So some will show that quality of life is really not impaired, but there have been a few that have shown that maybe there is a little bit impairment in quality of life. And sometimes this is the different outcomes there can be because the literature doesn't always have a uniform definition of what we're looking for, what the outcomes are. It might not be the best designed studies to really look at the longitudinal outcome of these patients. So there's been a kind of recent increase in multidisciplinary pediatric colorectal programs in the US and elsewhere over the past several years. And one goal of these patients is to provide multidisciplinary care to patients with Hirschsprung's disease, among other complex colorectal conditions. And so this allows an opportunity to really have a collaborative medical and surgical decision-making, along with many other team members, to really try to improve patient care and quality of care. It's not completely clear if we're having that effect yet. I think there still needs to be a look at what the outcomes of these different centers are, but there is some evidence that this decreased healthcare costs that we can, you know, more available to patients, have decreased visits, which I think is very convenient for patients. We can work to decrease anesthetic events because we can kind of combine, have a good plan going forward and not be seeing one doctor who plans one thing and another who plans another. And it can really hopefully help as we have these kind of teams to then provide an effective transition to adult care when that is needed. As I said, we're still trying to work on collecting data for this to know if the longitudinal outcomes really are different with these multidisciplinary centers, but that is definitely our hope. There is a pediatric colorectal and pelvic learning consortium that is trying to work on aggregating data among the different centers throughout the US, at least in an effort to try to better understand what the outcomes are and where there's potential room for improvement. So there can be lots of different people on these teams. And so certainly there's pediatric surgeons, but we also have pediatric gastroenterologists and nurses and advanced practice nurses. In some places, having the availability of pediatric urology or pediatric gynecology might be important. It's certainly not needed for the majority of patients with Hirschsprung's disease, but may come up for sure. And they can be good, team members to call on in those cases that's needed. Certainly psychology and child life specialists are helpful. Physical therapists and social workers and dietitians can all have a nice team with different specialties and different areas of expertise to help care for patients. I'll talk a little more about the role of the gastroenterologist because that's what I know best since that's what I do. So we have various different roles in Hirschsprung's disease. So we are often see patients before diagnosis too, depending on when the diagnosis is made. And so we can help with making the diagnosis, but we're also involved for various things like nutrition and diet and managing fluids and electrolytes. I'll come back to the rest of that in a minute. But for diet and nutrition, so certainly if there's a prolonged period before diagnosis, there can really be a lot of problems with feeding that can lead to failure to gain weight well, and even malnutrition. And so we often see patients related to that. There's also, some patients really still struggle with this even after surgery. And so we're often involved for those reasons as well. And definitely there can be, the colon, one of the jobs of the colon is to reabsorb water. So if that colon is, a large section of it is removed, or if there's an ileostomy, then we can certainly run into lots of problems with dehydration and need for fluid replacements and electrolyte replacements and monitoring for that. And monitoring salt supplementation and those sorts of things. And then some patients really have more problems with even intestinal failure. And so those would be managed in the silo of a GI clinic with more TPN and those sorts of things. So we are also sometimes needed to assess for other GI causes to symptoms. So depending on what the symptoms are, we've kind of already talked about a little bit, could there be kind of eosinophilic colitis or things we might need to do scopes to look for that. There may be symptoms that can overlap some of the symptoms patients with Hirschsprung's will have. So distension and things like that may be related to Hirschsprung's or may be related to something else. And so we might need to be looking with different laboratory tests and different scopes to look for things like inflammatory bowel disease or celiac disease or bacterial overgrowth in the intestine, which can sometimes cause some bloating and diarrhea, which may be a symptom patients had been having and we thought was related to Hirschsprung's, but maybe we need to look at other causes. And then Botox was mentioned before by Dr. Langer too, which is often done by a pediatric surgeon, but many pediatric gastroenterologists are also able to do those procedures as well, doing the injection of the Botox in the anal sphincter. And then manometry, which has been mentioned, I'm going to go into a little bit more detail, but anal rectal manometry and colonic manometry are also areas in which we play a role. So between the two, anal rectal manometry, I think gets used a lot more in evaluating kind of the post-surgical complications and or symptoms in Hirschsprung's, but colonic manometry certainly has its role as well. But anal rectal manometry is a way of really assessing the anal sphincter and assessing sensation. So these pictures, let's see if I can figure out the mouse thing. Whoops. Oh, there it is. So this picture here on the left, this orange catheter is the manometry catheter. There are all these silver markings along the way that are pressure sensors. And this white thing down here is a deflated balloon. I have it pictured next to an ink pen just to give some indication of size. So it's a thin catheter, it's flexible. It gets inserted transanally into the rectum. This is best done with a patient awake. That is how we can get the most information. But under some circumstances, we can do it with some amount of anesthetic, but that can sometimes affect the pressures and we can't get as much information. So this allows us to measure the pressures of the anal sphincter and kind of what is baseline resting tone. And we know kind of what normative values should be. So we'll know if it's too low or too high. It allows us to assess response to balloon inflation. So this picture on the right is just the balloon with a little bit of air in it. So we're able to put in air and remove air while it's inside the body. And this just shows kind of what it would look like with a little bit of air. So we can tell one thing is sensation. So when does a patient first sense anything in there and when do they sense that they might have to go to the bathroom? So we know, kind of if there is some impairment to sensing, which might be then leading to some of the ongoing problems that we're having. And then this test also allows us to look at defecation dynamics, or kind of a fancy term for kind of just the mechanism of pooping. So this is what we look at. This is the kind of output we get from high resolution anal rectal manometry. So there's also sort of standard manometry gives the line tracings that were pictured in Dr. Langer's talk, but this high resolution manometry is really nice and I think easy way to kind of to see what's going on. So this band over here just kind of orients you. This shows these colors correspond to different pressures. So the blues and greens are kind of lower in the pressure all the way up to reds and purples, which gets higher pressure. This first panel over here on the left is just a resting pressure. So you can see this band of green would correspond to where the anal sphincter is. And so this is just, measuring what the tone is of the anal sphincter when a patient is just at rest and not trying to go to the bathroom, not trying to hold anything in. Certainly if this is very low, perhaps there's been a sphincter injury or something, and that might indicate, why might be one reason why there might be some ongoing soiling. This next panel here is one of the things we have patients do during this test is squeeze like they're trying to hold back stool. So this you can see is this green band was at rest, and then we asked this patient to squeeze, and this is really good. We went up in the pressure scale, the reds and even purples. So this patient is really able to use those muscles well and hold stool in. Certainly if this squeeze is very weak and they're not able to increase much above resting tone, that again could be a reason why there's some issues with ongoing incontinence. And in particular, if you mixed a decreased sensation and decreased ability to squeeze, that could really be a problem with being able to maintain continence. This next panel, another thing we have people do, like I said, that defecation dynamics. So we have them bear down like they're trying to pass stool. And so we go from kind of a resting tone, and then we see this nice increase in pressure here means they're pushing and increasing pressure through the rectum. The problem here we're seeing with this is at the sphincter level, they're not relaxing their sphincter, which is what we'd like to see to let stool out. So this coloring here should go down to more of the blues and greens if we were really letting stool out appropriately. But some patients develop this kind of tightening of the sphincter instead. And often this comes from kind of stool holding behaviors and things like that. And we can then send to our physical therapist who we'll hear about later, and they can work on kind of retraining the ability to really relax as we're bearing down. And then down here, this is that rare reflex that Dr. Langer mentioned. So rectoanal inhibitory reflex. So when we inflate the balloon, which is just depicted by this green here, what we like to see is you see that green color decreases to the light blue. So this is a nice relaxation of the anal sphincter from balloon inflation. We don't see this in Hirschsprung's disease. So this test can be used to help with diagnosing Hirschsprung's in some patients because we wouldn't see that relaxation, or at least it would suggest it. It suggested biopsy is needed. So switching gears just a minute. So just thinking of kind of long-term follow-up. So we're hoping that kind of having multidisciplinary centers can also help us with the long-term and transitioning to adult care. There is, although we've talked, many patients with Hirschsprung's do very well, but some will still need ongoing care into adulthood. And we might not have always been great about how to make that transition. So there's, emerging literature that structured transition of medically or surgically complex pediatric patients for whatever diseases they may have to a provider for adults would improve their, quality of life and outcomes. And in particular for Hirschsprung's, I think the patients who would benefit most from this kind of structured follow-up and structured transition would be those who are more at risk of having long-term bowel dysfunction. So like we've talked about total colonic aganglionosis or very long segment disease, or if there's other kind of psychological or behavioral or developmental disabilities that might lead to longer term problems with bowel function, those would be really important patients to help with that transition, but really anyone could benefit from it. There are these guidelines published a couple of years ago, these European Society, I can't remember what the whole acronym means, but it's the European Society and it has to do with congenital anomalies of the intestinal tract. So they came up with guidelines regarding care for patients with Hirschsprung's disease, and part of their guidelines included information about transition. And so their recommendations included that we should start these sort of discussions about transition to adult care in adolescence before it's time, but just start the discussion and kind of help patients come up with individualized care plans so that all the appropriate disciplines that they need, now in the pediatric world, if they can have those in the adult world as well. That patients need to be given enough information and be increasingly engaged in their own kind of healthcare decision-making from an earlier age so they can really help, in that transition themselves to the adult care. And then it's, we need to help patients clearly identify who a future provider will be who has, knowledge of Hirschsprung's and care of Hirschsprung's patients. And ideally, there'd be this opportunity for having staged transition. So there's some liaison between the pediatric team and the adult team that they're going to go to, and that can look different in different places, and certainly is something that we work for other GI and surgical diseases too as we're transitioning patients. So I think this group published a paper and they went to look at, they asked the people who could tell us for sure if we really need this help with transition. So they polled a bunch of adult patients with Hirschsprung's disease to kind of say, hey, how was transition to adult care? What problems were identified? What needs did you have? And what would you have liked to have seen? And so, they kind of split it down into different domains that they were asking. This just kind of summarizes some of the things they said, but sort of the physical, psychosocial, educational, and then transitional needs that might be there might be, and what some of those challenges might be, and what the patients recommended that we could help with. And so certainly having support for optimal bowel function, and if there's still ongoing issues, having dietitians available to help with some of the issues that are ongoing, really, helping with ongoing coping strategies and having kind of peer-to-peer relations for people who also have Hirschsprung's as adults, and may, having those support groups were big as well. And then just kind of helping to patients, even starting in the teenage years, to know where to access information about Hirschsprung's and their own medical history. And then down in the bottom part, kind of their transition recommendations. And so the patients thought it would be helpful to, as kids are aging, to have some of their consultations partly without their parents available. And I think, sometimes we do this in other with other diseases as well. We might start a visit with a patient alone and then bring a parent in so that everyone has the opportunity to kind of talk through issues that are high on their mind, and they have that ability to advocate for themselves as well. They recommended that we start this transition process in the early teens, much like that other group I mentioned had recommended, and then establishing contact with an adult multidisciplinary team who has Hirschsprung's experience. So there is this in this group here who had kind of talked about the structured transition to long-term care. They had kind of tried to come up with ways to help facilitate information in that transition. And this looks similar to, I think, the passport from REACH. I think kind of a similar idea, and this is just one other, example of what they'd come up with, but kind of having some form of a card to carry or something, or ideally electronic, probably, information, and what information be important for patients and families to have kind of on hand anytime, just in case they end up, needing to seek care. And kind of knowing what the operation was and when it was done, and short or long segment, and who performed the operation, where was it performed, and any other relevant past medical history, what your bowel regimen is now, other medications and allergies. And then just important, and I think really helpful, and probably most of you have at home kind of binders of information about healthcare, but just sort of having operative reports and pathology reports and discharge summaries that are just sort of a nice summary of care that can really be helpful as you're transitioning. Because I think even when we have access to all the records, it can be a lot to weed through and figure out what are the pertinent parts. And I think if you have that kind of packet, you at least are empowered also to know and have that information available that you can kind of help the next provider. And then they recommended also kind of coming up with this transitional care medical summary. And so the idea is that the patient and their surgeon or whoever else is on their care team would help kind of formulate a document, if you will, to have more details than just that card would include, so that it's really, as you're moving on to working with a different team, they have all the really pertinent information. And some of it's similar to what I said, kind of what your original surgery was, and kind of where the transition zone is this, so we know if it's short or long segment. Have there been previous surgical complications? Have you had an exam under anesthesia? And if so, when was that most recent one, and any outcome from it? Hospitalizations, and when was the most recent one? And then, more specifics about surgical repair, as far as, is the dentate line intact? Are the sphincters intact? Was there a transition zone pull through? Are there other things related to the particular type of surgery you had? And then have there been strictures? And just really knowing, all the details of your care thus far. And then including other things too, like your stooling habits and what kind of bowel regimen you're using, what's been effective, any enterocolitis, was this before surgery, was this after surgery, and kind of what, treatments you've had for that, and any other medical history. And then pertinent, radiology testing too, like when was your last, have you had an x-ray recently? Just so we, when was that? Have you had a contrast enema recently? What was the result? Also to not have to duplicate if something was just done and you're transitioning, you don't need to repeat that right away. And then also anal rectal manometry or other colonic manometry, if that's been done, and what were the outcomes of those. So I think this is, just an example of a possible document, but I think it highlights a need. And I think what you guys are all already approaching with the passport and things, that it's just helpful to have this information in one place. And probably electronic is where we'll be going more than a piece of paper that we carry around, but I think it's could be quite helpful. So overall, our goal of kind of having these multidisciplinary teams is to help with structured transition to adult care, as well as improving the quality of care and outcomes for patients with Hirschsprung's. And that's all I have.
All right, thank you for that excellent talk. Does anyone have any questions here or on the chat?
Thank you. That was great. Thinking about the manometry, and also in general for parents of children that may have cognitive disabilities, like my son, who has Down syndrome in addition to HD. How do you think about that differently for that population?
Yeah, especially for anal rectal manometry, where we're needing that sort of the input from the patient. It's difficult. And certainly I think, in very young patients too, we can't get that sort of ability to participate as well. So it really depends on the kid. And so we'll often talk with parents too, and see how much they think their child will understand of what we're asking and be able to participate. We sometimes can't get the information that we need. Sometimes we can get enough, at least to know, resting tone of the sphincter, we might be able to do. We know that patients with Hirschsprung's won't have relaxation to that balloon inflation, but doing that in other kids, if we're still in that diagnostic phase, we might be able to get that done as well. And some of that part we can sometimes do under some anesthetic as well, if there's sort of worry about that. But yeah, we are a little bit limited sometimes if we're not at an age or developmental stage where a patient is able to, know what we mean when we say, push like you're trying to poop. That doesn't always, work. So sometimes those tests aren't as useful in that setting, but more just for the tone of the sphincter, I think.
So for the adult transition, I think I know it's different for parents with children who have cognitive disabilities. How does that need to change for that population? Have you, to what extent have you thought about that or addressed that?
Yeah, I mean, I don't think we've addressed it well, I will say right now. But I think that is a population where we really need to be the most helpful. Probably we need to identify caregivers for adults who are really attuned to working, with patients with Hirschsprung's and patients who might have developmental, disabilities and as well. And I think that's definitely work we need to do to help with that, because it's, I'm sure it sounds like some pediatric surgeons and such will still keep seeing patients for quite a while, but at some point there becomes some limitations within hospital systems and such that we really just have to transition. And so I think it's on us to figure out who are our adult colleagues who can help us with that. And hopefully we can start formulating some of that. I think that could be one output from having these centers, and when we aggregate information and maybe then have, if there's like a database or something, that would be great to say these are, places where throughout the country or world where we sent, patients, but I don't think we have that yet.
Yeah, I think we all have a pretty good idea of what's necessary, but finding partners in the adult world who are interested in taking this on and developing that expertise has been our biggest challenge. Mm-hmm. And part of that is just, it's just remuneration. Like the gastroenterologists and colorectal surgeons make way more money doing colonoscopies and operating on colon cancer than they do spending an hour with a family discussing bowel management. One model that they've done in Columbus now is there's a surgeon who's trained in colorectal surgery and in pediatric colorectal surgery, and she runs their transition clinic. So she actually has expertise in both areas. So there may be some innovative other ways of creating that population of adult providers, but so far most places have been spectacularly unsuccessful.
Yeah.
There is a question in the chat that says, any suggestions for finding a healthcare provider for adults who understands HD?
I think,
Well, I mean, that's one of the things that REACH does is it's kind of, we function as a clearinghouse a little bit, or as like we know who's out there, at least more than most people do. So, if we know where you are, and, we can sometimes help to connect you to a place where that expertise might be available.
And I think kind of seeking out, colorectal surgeons would be, one in the adult world. And then there are certainly many adult GI motility specialists who might be another, who's just sort of more attuned to working with conditions such as Hirschsprung's or other motility disorders, which there are some overlap with a lot of that, so that would be my first place to seek out if there's not a defined person.
I think also generally speaking, centers with pediatric and adult overlap is another place to go, although this is becoming more of a hot button issue in pediatrics as patients are surviving other diseases besides Hirschsprung disease. The two that come to mind are congenital heart disease, which is a big deal, and now we're needing adult providers to take care of those patients, and cystic fibrosis, where uniformly you look 25 years ago and patients were dying in the pediatric age group, but now they're surviving into the 30s, 40s, 50s regularly and need care by adult providers. So hopefully we will catch the coattails of that and start to find appropriate transitions for our Hirschsprung's patients as well. All right, there's another question. It was mentioned earlier that there may be a correlation between a sugary diet and diaper dermatitis. 16-month-old has been battling with severe diaper dermatitis for several months now. We have tried several over-the-counter topical ointments and a few prescribed topical ointments as well. Nothing seems to be helping. Any other thoughts or suggestions of what to try?
Ooh, I would defer to.
I think,
these
yeah,
experts
actually,
over
that's
here
a
for that.
great transition to Carrie Wilson, who's our nurse practitioner, since you'll be speaking next. And I think that's actually part of your talk, correct? All right, lovely. So we will get that answered in the next talk unless there's any other questions here. All right, lovely.